A warm welcome to you all, joining us from so many countries around the world and throughout the UK. It is an honor to be hosting our Social Prescribing Arts for Brain Health conference in partnership with the Global Social Prescribing Alliance. We are profoundly grateful to our opening chair, Michael Dooley, Treasurer of the College of Medicine, and to our highly respected global chairs and speakers. On behalf of Arts for Dementia, the UK charity specialising in weekly workshop practice at arts venues to re-energise and inspire people affected by early stage dementia and their companions, I should like to pay tribute to our late patron, Baroness Greengross, co-chair of the All-Party Parliamentary Group on Dementia, and to Lord Howarth of Newport, co-chair of the All-Party Parliamentary Group on Culture, Health and Wellbeing. Both spoke at the House of Lords earlier this year in support of amendments to the Health and Care Bill, promoting social prescription and specifically social prescribing to arts for brain health. Sally's wisdom and support had powered Arts for Dementia's advances for over a decade. Some 10 million people around the world are expected to be diagnosed with dementia this year. Their natural fears compounded by stigma. Creating and being seen to participate in imaginative artistic endeavour can transform their despair to desire. By arts throughout, I mean wide-ranging cultural and well-being activities to revitalise the soul. It is everyone's human right to participate in arts in the community, but for people embarking on life with a potential dementia, this can be a challenge social prescribing can now meet. Through referral by GPs, grateful to be able to refer fearful patients to enjoyable, constructive treatment to preserve their brain health. Delays in diagnosis heightens the need for arts prescription at the onset of symptoms. Joining social arts groups of personal interest empowers people to preserve their sense of normalcy, cultural interests, identity, and well-being in the community for years longer. Sharing imaginative ideas, creating together helps modify risk factors for dementia and nurtures resilience for both person and carer. Social prescribing, as you know so well, connects patients to local arts programs of personal and exciting interest. And in choosing to participate, whether peri or post-diagnosis, they are taking enjoyably constructive action to preserve their brain health. Today's conference marks, I think, the apogee of our webinar series to raise further awareness of best practice following the publication of our report, Arts for Brain Health, Social Prescribing, Transforming the Diagnostic Narrative for Dementia from Despair to Desire. We have heard how in some developing countries, social prescribing is a natural outcome of communities protecting their elders. For example, weaving in the Andes, basket making in Kenya. It will be fascinating to hear from our international speakers today how social prescribing is developing in your countries, the pathway from patient via link worker to arts program, whether referred from the GP or local agencies, the advances and the barriers. Lord Howarth, also a chair of the trustees of the National Centre for Creative Health, and Dr. Michael Dixon, chair of the College of Medicine and NHS clinical champion for social prescribing, have recorded special talks. Our strategic keynote speakers, James Sanderson, NHS Director of Community Health and Personalised Care, and Dr. Daisy Fancourt, Director of the World Health Organization, Collaborating Centre for Arts and Health, set the context. Dr. Bogdan Chivajurka, Development Lead, and Hamad Khan, Development Officer at the Global Social Prescribing Alliance, discussed social prescribing advances around the world and the vital student champion scheme in which arts and medical students interact with Arts for Brain Health participants, one of whom, Ron Bennett, presents the lived experience. I shall outline Arts Prescription Workshop model. Sean Brand, co-chair of the Social Prescribing Network, with chair presentations on the social prescription pathway from Australia, Singapore, and Portugal. And Alexandra Coulter, Director of the National Centre for Creative Health, is chairing arts prescription practices from Italy, Austria, and Canada. Innovative advances, collaborations at fascinating different stages of development. Timon Filigov chairs the final debate on funding sustainable prescription programs between Max Patton of the Arts Council England, Chris Easton of NHS Charities Together, and Joshua Ryan, National Academy's Thriving Communities Lead. And now over to Lord Howarth and then Michael Dixon. Thank you, Alan.
It's a great pleasure and privilege for me to have the opportunity to speak at this Global Social Prescribing Arts for Brain Health webinar, which is one in a series of very important webinars that Veronica Franklin Gould has organized over many months past. The creative health movement is reaching across boundaries between the NHS and social care, the arts and the voluntary sector, and increasingly around the world, demonstrating the power of collaboration to prevent illness and enhance health and well-being. In the 3 years since the NHS long-term plan placed a new emphasis on prevention, social prescribing, non-clinical intervention referred by GPs through link workers, has been central to the strategy, and the arts central to social prescribing. The NHS and the Department of Health brought together key partners from across government and the voluntary sector to found the National Academy for Social Prescribing to guide development, partnership practice, and training. Much more needs to be done to develop preventative strategies, but this commitment to social prescribing is encouraging. Arts Council England's 10-year strategy, Let's Create, has introduced a creative health and well-being plan to promote collaboration between organisations and practitioners in the arts and the health and social care sectors. There is an increasing evidence base showing profound health and well-being benefits of engaging in creative activity. Dr. Daisy Fancourt's reports for the Department of Culture, Media and Sport and for the World Health Organization are important resources. The Creative Health Inquiry of the All-Party Group on Culture, Health and Wellbeing led to the foundation of our National Centre for Creative Health to play a pivotal role in promoting collaboration and influencing policymakers, enabling creative health to become integral to health and social care and wider systems. The new integrated care boards are increasingly embracing creative health. Professor Martin Marshall, until very recently chair of the Royal College of General Practitioners, points out that the shift for us in general practice is not just engaging with the medical activities which are core, but to engage with social activities and make sure the two are aligned. That culture change is happening in medical education. GPs are increasingly incorporating creative health approaches into their curriculum and developing avenues for continuing professional development in this area. The next generation of clinicians are recognizing the benefits of creative health, finding that the approach is welcomed by their patients, particularly when recommended by a trusted GP. Social prescribing of creative health activity is opening up new opportunities to people earlier than ever before in their journey through dementia, to re-engage their cultural and creative interests. Engaging their imagination empowers them to preserve brain health and resilience in the community. There can be years between the appearance of early symptoms and the moment at which someone receives a memory assessment and a diagnosis. This could be a lonely and fearful time during which the arts can be particularly sustaining. Creative activity slows the deterioration of the brain. The benefits of engagement with creative activity continue for a long time, helping to preserve independence, health, and well-being. Social prescribing to arts for brain health, properly resourced, can keep people healthier for longer and relieve pressures on the NHS as we face a crisis in funding a health and social care system whose rising costs constantly outstrip the growth of our economy. We know that these preventative strategies need to be central to policy. Focusing more on wellness, on empowering activities that help preserve brain health, as well as necessary clinical assessment, we must harness creative health to help us become a healthy and health-creating society. We believe that social prescribing of creative health, of arts for brain health activities, can help forge stronger bonds in society. Shared creative activities can mitigate loneliness, strengthen mutuality, and develop community resilience. This is a time for all of us to consider new approaches and policies reflecting our humanity.
Thank you, Alan, very much. Now we're going to hear from Michael Dixon.
It's a real pleasure to be speaking at this conference, and I'm so sorry I can't be with you here today in person. But social prescription has advanced amazingly over only 4 or 5 years. Now, some of you will say, well, social prescription is as old as the hills, going back to the Peckham Project, back to developments at Bromley by Bow in Newcastle, and even my own practice in Devon. But the idea of the link worker and the idea of it as a national popular movement is actually very, very recent, only started in 2016. And yet, over those 4 years, we have been able, as a group, to create social prescription as a national model with universal rollout. There are now 2 or 3 social prescribing link workers in every GP practice, or group of practices, I should say. And extraordinarily, NHS England has completely met its targets in terms of the number of interviews and people helped and link workers that exist. So it is an extraordinary story in terms of realizing that we do need to go upstream and help people address inequalities at root, and often starting with benefits advice, housing advice, employment help, but then developing in all sorts of ways to create something that gives back people meaning and purpose to their lives. Now that's sort of where today's conference comes in, because the arts may seem counterintuitive as something that is important for health, but is crucially so, because arts not only develop our aesthetic selves, or not only develop interests, provide something for people to really take an interest in, but also it's about people doing this often together. It's often about bringing people together and feeling a part of an organisation, whether in the arts it's a singing group, a reading group, or whatever. And in this field that we're talking about today, dementia, I think even more so, because it's sometimes seen as arts interventions for people who already have dementia, but we've actually got to go upstream there as well. We've got to start looking at how the arts are part of preserving brain health in the first place, part of making people's lives much more fulfilling, and therefore reducing the number of people, or the rate at which people develop memory problems. So absolutely crucial, I think, in the message today is go in early, make sure that your patients, if you're a GP, or if you're a person, that you yourself take a real interest in the arts as something that can keep your brain developing and going. And even as our brains get older, and inevitably with an aging population, we're all going to find that our memories are less good and our interests diminish as we get older. The arts crucial again, because if we've got a firm basis and interest in the arts, then if our brains do become less useful, effective as we get older, then the arts provide us with that real base of interest and connection which exists. So I'm a real fan of arts and dementia. I think the whole movement created by Veronica has been an extraordinary process of banging doors open, not accepting anything for granted, and also challenging received opinion. Received opinion being that the arts may not be relevant, and if they are relevant, it's for advanced dementia. But what I think she has done is to make us all realise that the arts are intrinsic to preventing us falling ill in terms of reducing the progress of any illness that we might have. And finally, if we've had a basis in the arts, when we do become ill, when we do find our memories are failing, giving us something that we can connect with and that can make a quality of life that we otherwise wouldn't have. So I'm really looking forward to seeing the recording of this conference, but, and as I say, I'm sorry I can't be with you here today, but I do feel this is an area that is crucial and really important, and I look forward to hearing what everyone else has been able to say.
Thank you so much, Michael. Actually, like our colleagues here today, our aim is to provide a platform to showcase best practice by others. Anyway, so continuing this exciting collaborative journey, we welcome Michael Dooley to chair our opening session.
First of all, thank you all very much for attending, and thank you for having me as chairman. I'm actually an imposter. I'm standing in for Michael Dixon, who can't be here. But it's a great privilege to be here. And I know she doesn't want to be thanked, but I want to thank Veronica and all the team who put this together, because I think it's so important from a personal approach. That my mother had dementia. But I think what I love about the work that you're doing is all about teamwork and working together. Creating a multidisciplinary team is great for the patient. But without further ado, hand over first of all to James Sanderson, who's Director of Community Health and Personalised Care at NHS England, and he leads a range of programs supporting people to have greater choice and control over health and well-being. And thank you so much for coming, James, or attending.
Thank you very much, Michael, and thank you also to Veronica and Nigel. I just wanted to start by congratulating everybody that's joined this conference this afternoon, because looking down the list of attendees, I can see so many pioneers in this space of promoting the arts for health and well-being, and specifically for dementia. And you really have been trailblazers that have enabled policymakers and people across health systems across the world really take stock of the way in which they were approaching health, and really get some momentum behind national initiatives. And none of that has been possible without the really, really groundbreaking work that pioneers like yourselves have done. And congratulations to Veronica, Nigel, and everybody at Arts for Dementia for really tackling this course head on and pushing the boundaries of what has been possible. So I think you know, the momentum that we've got now is down to everybody's collective and individual hard work. So on the basis that we all, I think, share the view that the arts are hugely transformative for health and well-being and hugely influential, we've been all working on various pursuits over many years to ensure that this gains the recognition that it deserves within health policy contexts. The really positive thing now in England is that we have social prescribing part of national policy. So in 2019, we put social prescribing into the long-term plan for the NHS, and we said that psychosocial support, work in the arts and culture activities, sport and exercise, natural environment, those areas had as much hope and possibility of transforming the health service as digital technology and other advancements in medications. We said that social prescribing should be part of the offer that every patient visiting a GP in England gets. We recognise that there was a real importance in providing support for people who experience social issues rather than medical issues. But we also recognise the importance of the benefit of arts and culture alongside traditional medical approaches. And because of that, we were able to put in place a network of link workers, people that could be in primary care networks whose sole purpose it was to connect people to social activities in their communities, to find out what matters to individuals, to work with them to develop a core plan of things that are going to improve their health and well-being through non-invasive, non-pharmaceutical means. And social prescribing has really taken off since that point. We've now seen 1.3 million people benefit. We've got a network of around 3,000 link workers now embedded in primary care, and that network continues to grow. We're in the process of recruiting more and more people all the time, not just because of the recognition of the benefits of the system in supporting practices, but also, and importantly, the recognition of the benefit that this has to people. And I think this is hugely transformative. Social prescribing addresses a real challenge in the system, 1 in 5 GP appointments being non-medical need. We know that the benefits of aging are vast. You know, we've had a 17-year increase in life expectancy in this country over the past 70 years, which is a huge, huge achievement. But we know that, as we've heard from Michael and Lord Howarth, we know that the challenges of aging, the types of conditions that we're going to be living with for a long period of time, are significantly challenging, and many of those, like dementia, do not have a cure associated with them. So how we can support people through other means is incredibly important. We've also seen not just the growth of social prescribing in this country, but the growth of social prescribing around the world. I was very fortunate to be in Singapore last week with colleagues from around the globe, including Sean, who you're hearing from later, who were talking about how beneficial social prescribing has been in their area as well. We've seen not only the National Academy for Social Prescribing take shape in England over the last 3 years, really championing social prescribing. We now see the opening of the Canadian Institute for Social Prescribing in Canada, which is focused in a similar way to the National Academy for Social Prescribing. And Lord Howarth himself has launched a commission as part of the National Centre for Creative Health to take forward further advancements in how we can mission arts-based activities to support health and well-being. So not only is the work that you've all been doing for many years now recognised for its true importance and its true transformative nature, what we're seeing is the infrastructure growing, not just in this country, but around the world, to support this to happen at a huge scale. And I think that is terribly, terribly exciting. We've got now a global movement. The Global Social Prescribing Alliance has created a playbook recently to enable countries to easily adopt the basis of social prescribing, the infrastructure that they need to put it in place. And we've actually got 25 countries now that we're working with and that come together as part of a network that can demonstrate huge, huge advancements in those areas. So, you know, you are all part of something that's truly revolutionary for health and well-being, and is truly a global movement. And I think it's exciting times that we can now properly be bold about our wishes of getting the arts up there as part of mainstream medical treatment and support. In addition to that, we need to think beyond health systems. We need to think about how we can connect people in other ways, how we can have people in communities that are trained up on knowing the benefits of the arts. But also, we've got a long way to go in convincing the public, those people that can connect themselves, you know, ensuring that the information is out there so that we know how beneficial these activities are for our health and well-being, and in particular for our brain health. And you heard Michael say there about, you know, the preventative nature of arts in terms of deterioration. Now, you know, if we can get those messages out, you know, that's going to be great for people and for their health and well-being, as well as it is for healthcare systems. So thank you very much to all of you for everything that you've done so far in this great movement. Well done to everybody that's pioneered such great opportunities for improving health and well-being. And I'm really pleased that we've brought all of that pioneering and all of that entrepreneurial spirit together with now what is a solid infrastructure within healthcare systems, not just in England, but around the world. Thank you.
James, thank you so much. I just want to ask you one question, James. I'm and people get fed up with me asking is, I'm involved very much with the College of Medicine, and I hope people can support that, and it's a great organisation. But what I do find is, how can we spread the good? I'm a gynecologist and therefore very much involved with secondary care. And when you speak to my colleagues in secondary care, they really do not know, and they look completely blank about the role of social prescribing, or what social prescribing is. And I think they could have a huge role, and definitely areas of gynecology and fertility and menopause, etc., I'm involved with, could really benefit from linking up with linked workers. But the knowledge of social prescribing in secondary care is very, very poor. And I'm not sure if you had any thoughts about that.
I think it's a very good point, Michael. I think, you know, I completely agree with you, first off, that, you know, the benefits of social prescribing linked to various interventions in secondary care are huge. And I think we've only just started scratching the surface there. Social prescribing, you know, has begun its life in general practice, and as sort of, you know, bridging that gap between general practice and in community services as well, where we see linked workers now incorporated as part of multidisciplinary teams working across communities, whether that's working alongside occupational therapists and physios and pharmacists. There's a great opportunity for bringing those teams together in more neighbourhood specific areas to really push this agenda forward. I think in secondary care, we're starting to see some of the crossover in terms of treatment of various conditions like cancer, for example, where a lot of linked workers are working in that area alongside medical interventions for people living with cancer. We've also seen the benefits of linked workers being placed in accident and emergency departments in secondary care to support those individuals who are turning up to A&E with more social needs. But I think across other specialisms, whether that's gynecology, or whether that's in paediatric wards, or whether that's linked to other long-term conditions, including areas like MSK, where there's a huge potential benefit. I think we've only just started scratching the surface. And I think now that we've got the really significant infrastructure in place now in primary care, the opportunity of further growing that workforce is really upon us.
I know it's so important, is connecting primary care to social care, to voluntary care, to secondary care, and in the end have just care. I'm just looking at the questions, and Dimitar's move. Is Anne there? I see you've moved from social prescribing to working with local councils to empower and upskill them to support health and well-being in their communities. And I wonder if you'd like to sort of mention a little bit about that, Anne.
Yeah, hello. Thank you. Just briefly, if you will, because we want to keep to Arts for Brain Health.
Yeah.
Thank you very
Yeah,
much.
certainly. I was funded by the National Academy of Social Prescribing last year and the Thriving Communities Fund for a one-year project in Somerset, and we did we commissioned 7 activities in Somerset, and that project ended in May, and I'm now working with the Association of Local Councils in Somerset, working with the local council sector. So basically bridging the gap between the local council sector and the county council sector, and trying to connect those in with all these other networks that we connected in with last year. So that's a 3-year programme, so I'm really looking forward to it.
And everybody do look at the chat. I think we can get it printed off at the end, because there's lots of good references coming up and some very good comments. Any further questions for James, or any further points you'd like to raise, James? But thank you so much.
And just, I mean, just to mention, obviously, the work that's gone on by the National Academy for Social Prescribing in relation to Thriving Communities programme, and I know Joshua's up later on. I mean, that's been groundbreaking in bringing programmes together, like you've just heard, bridging the gap between various community providers and with statutory bodies as well. And you know, the Arts for Brain Health has played an important role in moving some of those programs forward. And I think, you know, we've got momentum now. I mean, this is the big thing. We've got momentum, we've got the evidence that it works, we've got the infrastructure to do it. And for all of those on the call that are working to put this in place or working in brain health, hopefully this will give them confidence to recognise that what they're doing is known to be important and of huge value for the future of healthcare systems. And
I think just to reinforce that, James, you know, work that I've done within the community, the work and the problems with mental health and dementia and how arts can benefit individuals and make a huge difference, not only to the individual's life, but their family life, and the whole connecting the community is so important and like to everybody.
I want to thank you so much, Michael, for stepping in like this. And James, I'm mortified that Daisy isn't here. We'll try and insert a talk to get the impact, the World Health Organization impact that she writes so well about. But James, thank you for setting the contact so absolutely superbly for global social prescribing.
No, thank you so much, James. Brilliant. And I hope we all meet together.
And so now I should very much like to welcome our co-host, Bogdan Shivajurka, who is development lead of the Global Social Prescribing Alliance, who's going to chair the next session. Thank you so much. It's been a privilege to work with you.
Thank you very much, Veronica, and warm welcome to you all. We've seen people from all around the world. I can see colleagues all around, from Australia to Singapore, Austria, and so on and so forth. And what a beautiful introduction from Walt Howarth, from Michael Dixon and James, paying tribute to the work that you've all been doing to push social prescribing further, far beyond the boundaries of the UK, and showing its impact around the world. In this session, we will be discussing about the impact that social prescribing has had around the world, and then you will be hearing from some of our international partners, giving you real examples from the ground of what this looks like in country around the world as well. I will share with you some slides just to give you a bit of background. As James was saying, thanks to many of the partners that we've had, we've been able to put together a true global movement, and I can see we have colleagues tuning in from every single corner of the world, and we're very grateful for all the support. I've run out of space for all the logos of the people included in there, so I hope I've not missed too many partners in there, but the Alliance is a true global community of partners all coming together. It's a knowledge sharing platform, being able to spread and scale innovation across the world as well. If you'd like to find out more, there's a bunch of resources, open source and freely available online. You can access all of these, be it the social prescribing playbook, or if you're interested more in student work, you can find out more via the link provided in there. And we've also recently published with authors from over 20 countries a global health publication with developments from social prescribing around the world as well. When you look at the map, there's enthusiastic individuals like the ones you see in the chats today, and people who are eager to get involved and get stuck in the work alongside their busy day-to-day jobs. They are volunteers supporting this movement and pushing it further alongside yourselves. They represent over 23 countries around the world, and what they have achieved is truly incredible. They get together and organize conferences like the one James was mentioning earlier in Singapore, and I know Dr. Lee will be talking more about this later, or in the USA, where there's recently been a workshop on designing social prescribing for US policy, as well as the great work done by the Canadian Institute for Social Prescribing on a new definition for social prescribing that it has been written up and launched through a paper as well. But when you look at those individuals, what you find is that they are more than working with each other, more than in a professional relationship. It's a true close-knit family of individuals, and it reminds us of how social prescribing started within England in the first place. Everybody's there for one another. Everybody flies around the world and supports one another to make sure their countries can thrive. And we are aware that one size does not fit all. And so we want to make sure we have alternative models and alternative ways of looking at social prescribing for different contexts as well. We've had the privilege of hosting several learning site visits. So for our international colleagues who are out there and who'd be keen to join us for in-person site visits or study visits, do drop us a note. We'd be more than happy to welcome you. We've had ministers from Nigeria, from Japan, and presented in various places with support from the World Health Organization as well. I also wanted to mention something because Lord Howarth did mention the power of the future generation and the importance of medical education that was highlighted earlier on. We've developed a program with NHS England in collaboration called the Social Prescribing Champions Program. And this is open to clinical and non-clinical staff. Back to Michael Dooley's comment around secondary care, just to note that this training program does include consultant cardiologists or secondary care staff members, but it also includes receptionists, discharge coordinators, managers, physiotherapists, pharmacists, so allied healthcare professionals, not just doctors. It includes a wide range of multidisciplinary team champions, all of whom get to learn about social prescribing and then peer teach each other within the workplace and get together to spread the word about social prescribing. And taking one step further in there, going even backwards in the early days of our training, we are working with thousands and thousands of students who Veronica has supported very dearly over the years, and we're very grateful for that. But these students have been marvelous at changing and shifting the curriculum, not just in medical schools, but in universities across the UK. And we're grateful for Anya de Jong, one of the occupational therapists now, who started as a student, who's forced us to move away from just medical schools into allied health professionals roles and working together to change and shift the curriculum across as well. When you look at what they've accomplished over 1,250 teaching sessions, and the deans of the universities are now advocating for a curriculum shift to make sure the future generation is equipped with the right skills for the right demographic in the 21st century as well. And I'll leave you with a thought before I move on to the global image of social prescribing, which Hamad, my colleague, will be talking about and going in depth into some of the examples around the world. But just a bit of a save the date moment, because as you all know, we're passionate individuals and many of you will be contributing to this, but do save the date. Social Prescribing Day is an awareness campaign that happens every single year. And this year it happens on the 9th of March. And we do hope you'll be joining us on the 9th of March via social media through various events. There's some examples in those pictures from some of our partners in the past, but it's a global campaign for raising the profile of social prescribing. So without further ado, what I'll do now, Veronica, is I will hand over to my colleague Hamad, who will talk about the global map for social prescribing, which we developed with over 23 countries around the world.
Thanks, Bogdan, and thank you, everyone. If I could just start by sharing my screen. And it's such a pleasure to be able to have the opportunity to talk to you all today about the global situation of social prescribing. As Bogdan said, my name is Hamad Khan. I'm the development support for the Global Social Prescribing Alliance. And we all know that social prescribing has grown in its profile, prevalence and practice over the recent years. I mean, we've heard much of, from Bogdan's presentation already, and much of it is thanks to the many speakers who are here this afternoon as well. Bogdan mentioned the Global Social Prescribing Alliance and its network of international partners that consider it a multi-sectoral network of collaborators, mobilizers and catalyzers. And we are proud to have a representation from 23 countries around the world and hope for that number to grow much more in the future. And it is through their kind collaboration and cooperation that we were able to collect sort of vignettes or small profiles of what social prescribing is, how social prescribing is demonstrated in practice within these different countries and their health system contexts. And through that effort, we were able to create a world map of social prescribing, as it were. And social prescribing is now truly a global movement that spans across the breadth of the world. And you can just see that within the diversity of its terminology. In the UK, we obviously talk about social prescribing link workers. In Canada, that can be referred to as community connectors. Social workers, they're described as social workers in Portugal. Beautifully in Iran, in Persian, they describe them as behvazes. Persian beh meaning well-being, and vazes being skilled, people who are particularly skilled for the well-being of their community. In India, we have the accredited social health health activist workers, who also can be described as social prescribing link workers, and Asha in Hindi, of course, meaning hope as well, delivering hope for the community and people within their community. In Japan, you have Saikatsu Shiens, who deliver long-term community support and care for people to ensure that they're integrating and engaging with community services for the betterment of their overall health and well-being. And you've got wellbeing coordinators and community connectors in Singapore and Australia, respectively. Now, I won't have much time to go into much detail at all about any of these countries, but if you could just indulge me in giving you a whistle-stop tour and perhaps a whiplash-inducing tour about how social prescribing looks like across the world. And of course, we can start off with England. We've heard much of England being the first country to nationally implement social prescribing into policy with the NHS long-term plan in 2019. And we've also had commitments for further recruitment for the social prescribing link worker workforce to increase it up to 4,000 by winter's end. But a lot of countries and a lot of papers and research talks about the UK, but it's important to recognise the diversity in practice and the developments happening within the nations of the United Kingdom. Wales has remarkably developed their national framework, quite superbly rather, meant to say the All Wales model of social prescribing, and it puts particular emphasis on the community supports, because recent research found that much more social prescribing referrals happens within community settings, which is slightly opposed to the England primary care model. And Scotland in its own right has quite a lot of developments in it, and quite uniquely has themed link workers who are particularly skilled and have gained the competence in dealing with vulnerable populations, be that homelessness or refugee populations, so that they can ensure that access and health outcomes are delivered for those that most vitally need it. Moving on to the Netherlands, if we can. So the Netherlands has, I'm not going to practice my Dutch here, but they have their wellbeing on prescription, which is a sort of national knowledge network of primary care providers, welfare workers and social workers. And they have their framework described as a burger, because apparently everyone loves and understands a burger. And my crude translation over here of that model as well shows that there is similarity in principle, but diversity in practice. And in principle, it's much the same. You have screening and referrals of patients and a wellbeing coach appointment, and that wellbeing coach is community-based. They have competency in their local environment so that they can ensure that appropriate referrals are made for their patients. And similar developments happen in Finland, and they happen in Austria, and they happen in Spain too. I'm not going to take too much time. I'll just skip through it. Portugal we'll hear much from later on as well. But I think the key thing particularly about Spain to take note of is they have this Champions program. Of course, we have the NHS Clinical Champions program, and it's nice to see that something is emulated within Spain too. They offer a 3-hour course for the health workforce to become agents of change within their health centres, so that they too can advocate and help propagate the principles of social prescribing, the practice of holistic patient-centred care. And just to go and note about championing, it's really important that we think about the future health workforce, because current health education informs future clinical practice. And if social prescribing is about modernizing our models of care and our health system, then it's so much more vital to ensure that we have the future workforce and the future generation knowing, engaging and working to develop and implement social prescribing, not just in their practice and knowledge, but in their education too. And so we now have a global social prescribing student council that was established in 2020, and there's much more developments to come from that, but we have events all around the world to increase the awareness of social prescribing across campuses and to ensure that social prescribing is firmly placed within health curricula across the world. And just to end on that note, as a personal experience as well, I can say that I knew about social prescribing as a student. And as a student, I was so very fortunate enough to be afforded the opportunity to volunteer with Arts with Dementia and Veronica's workshop, and there I saw Ron, who I hope will be speaking to, right now, and Ron was an Arts with Dementia participant. And I can say from my personal experience then as a neuroscience graduate, I was able to see neurodegeneration beyond its physical symptoms that we talk about, and social prescribing as a treatment or as a coping mechanism to help increase well-being and wellness in individuals was something that wasn't afforded to me in my university education. And so I can speak from personal experience to say how transformative it is, because we all know that health exists beyond the membrane of our biology. And I saw that at Arts with Dementia, and it was a pleasure to be able to volunteer. And I think Ron will be speaking to that.
Brilliant. Thank you so much, Ahmad. And let us welcome Ron. Ron, over to you. And thank you ever so much for being here with us and sharing your experience. We're very grateful.
Yeah, I've had the pleasure of meeting you when I was at the Playhouse. And I enjoy every minute when I come to the Playhouse. It's totally fun. I met quite a load of new friends through it. The staff at the Playhouse are wonderful. They help out, and you know, we do plays, and I would never dream of doing anything like that. I was always a shy person and sit on my own and wouldn't talk to anybody quite a lot, but I managed to come out my shell and be able to talk to people and laugh as well. It's just amazing. You know, you go on to an empty house, but on a Wednesday when I come to the Playhouse, it's just fun. Everyone laughs. We have a tea break, we have biscuits, and we meet up for coffee as well in a week, some of us. And you know, we go shopping and meet up in a coffee shop, and we talk about what we're doing at the play, and it's just a new experience. It gives me something to look forward to, and something what I never thought I'd do. Never thought I'd join a Playhouse or do a play. Always considered myself not that good. And when the doctor decided me to go there, because I was a bit scared, a bit nervous, but within a couple of hours, it was just lovely. Just lovely to meet up with a lot of people, especially Veronica, who talked to me a lot and helped me, you know, settle in. And yeah, it's just lovely.
Ron, it's so lovely to see you. Would you like to tell us how you came to hear about the Southwark Playhouse?
Yeah, I found it through my doctor. I went to see my mental health doctor, and she asked me to come along. I think she booked the appointment to come and see Veronica. I think it was, I met first. And at first I said, oh, I don't really know, because the scaredness of not being liked, I think. And I forget things sometimes, and I think people look at you funny. But, you know, I've got through it from my doctor, you know.
You were the life and soul, together with Ahmad, actually, who I remember him standing up leading these wonderful projects. But you were terribly funny in lockdown when you had a, you know, you composed this scenario with someone hopping about.
Yeah, I've done Elvis Presley, didn't I?
You did. You really co-curated in the most fantastic way. And tell me now about continuing. So this was a program which we were doing for a year, and you've been doing it ever since.
Yes. This is the one I'm doing now is different what I've started. Mm-hmm. This is a over 61 now for over 60s. And that is brilliant, because it's just, everyone's so funny, you know. And as I said, I look forward to going on a Wednesday morning. I think sometime the first one there, waiting to get in.
I think
so, right. Yeah, it's just like we go for coffee after, as I said, in a week we might meet up and say, oh, I'm going Tesco's and there's coffee shops next door, so we meet up and have a coffee.
Brilliant. So it's a family.
Yeah, it's just get you out.
Drama family, Playhouse family.
Yeah, it's like today, if I wasn't here, I'd be sitting indoors watching that daytime television, driving around a bend.
You were the life and soul. I remember you had kind of orange walls and hilarious pictures, and you were acting. Life was, you're a people person, and it was, you brought everything to life. It was wonderful. Yeah. I think the best thing, I see the doctor today, funny enough, I had a doctor appointment, and I was telling her about us, and I thanked her for, I think it's a couple of years now I've been here. And I thanked her for recommending me, and she said, "Oh," and I told her what we'd be doing, and we got our play in the fortnight, not tomorrow, the following Wednesday. So we're doing a play. All got our different things. Mine is in a waiting room with another woman, and we're waiting to be seen. And I'm a moany getting it. I moan a lot. Thank you so much. You said also it helped you get over pain, as far as I remember. Yeah. You were in great pain, and my legs are still in pain now. I've got patches on for morphine patches because my legs, I can't bend them. It swells up.
It's so easy to sit indoors and say, I can't be bothered to go out, you know. Theatre gets me out, you know, it gets me there because, as I said, you have a coffee break, you have a laugh, and everyone got their different personalities, you know, and everyone's funny, as you said. And yeah, so.
Oh, well, that's wonderful. Shall I just tell everybody about the model of this program?
Yes.
So Ron has been continuing thank you very much. Ron has been continuing weekly drama workshops that David Workman has been running at the Southwark Playhouse since we began our Arts for Brain Health social prescribing program in 2020. And at the end of that year, the National Academy for Social Prescribing's Thriving Communities Fund set out the structure for collaborative, sustainable arts prescription, which I have ever since been keen to promote as a universal arts for health model. It will be really interesting to hear Joshua Ryan's update. Now, so this is the Arts for Brain Health social prescribing model. At the end of that year, 2020, National Academy for Social Prescribing's Thriving Communities Fund set out the structure for collaborative, sustainable arts prescription, which I have ever since been keen to promote as a universal arts for health model. It'll be really interesting to hear Josh's update. Naturally, thinking of the person's need, central to the Arts for Brain Health prescription is the programme of weekly participatory arts or wellbeing workshops at cultural venues for people experiencing early symptoms of mild cognitive impairment or a potential dementia and their companions. Led by artists trained in early stage dementia communication, their focus not on stigmatizing dementia, but on the empowering use of arts to preserve brain health. The workshops challenging but achievable, rewarding for all, designed in consultation with potential participants to re-energize and inspire. Whether or not the diagnosis is ultimately a dementia, participants enjoy cognitive benefits. If a diagnosis is confirmed, participants remain part of the group, co-curating, improvising, inspiring each other. The ideal program format is 3 8-week terms of weekly 2-hour workshops. Time to coincide with the academic year so as to involve students. I think I might just move the next one on. Time to involve students of the art form and medical students interacting together, as we've heard from Hamad, with participants for mutual benefit, to understand the capabilities as well as the challenges of people whose cognitive impairment is mild, to support the arts team and evaluation, to share the learning through their dissertations and help spread the practice. So the cost of each weekly arts project plus project is £8,000 plus the project coordinator fee. So it's quite useful to actually have an understanding of how much these programs cost. Participant referral is through social prescribing at the onset of symptoms, a GP referring their patient to their primary care link worker who can empower them to engage in local arts activity to preserve their brain health. Arts for Health dissemination. The UK arts organisations can disseminate their programmes and link workers can find them through Culture, Health and Wellbeing Alliance, Social Prescribing Network and Thriving Communities regional champions. And they can locate or post arts opportunities on the Arts for Dementia website. Arts organisations can also liaise directly with their local surgeries, primary care network link workers who are keen to hear of art prescription opportunities. Collaboration is the way forward to raise maximum awareness, funding and sustainability. A cross-sector arts and health consortium with perhaps more than one arts organisation to offer choice, working together, planning content with potential participants with lived experience, building relationships. With Thriving Communities' place-based model in mind for involving all stakeholders, the ideal Arts for Health Consortium starts with the arts prescription. So the arts organisation who is providing the weekly programme, maybe more than one arts organisation for variety. The local primary care network, whose GP and social prescribing link worker, glad to be able to offer arts as health-enhancing treatment at this early stage, will refer participants. Local authority, proud to fund arts and health programmes, ethnic, cultural, and or disability groups. University, very important for arts and medical students, the Students' Champion Scheme. So the Arts Perception Consortium is then well placed to raise awareness to all stakeholders and attract cross-sector funding. Engaging in weekly arts practice can enable participants to preserve their health, their brain health, and resilience in the community for years longer. Some 3 years, we and Alzheimer's Scotland observe, and substantially save health and social care costs. Thank you, and thank you, Bogdan, for the moment. We come back to you.
Thank you.
And now I should like to introduce Sian Brand to chair the next session, the Social Prescription Pathway. Thank you.
So much, Veronica, and great to see those slides there. Wow, what a wonderful afternoon already. My mind is buzzing. Thanks, Ron, for sharing your story. It was so heartwarming. I also live with pain, so anything that can help reduce pain and, you know, having those connections in the community, making friends, and laughter, my goodness, laughter is so important, isn't it? So I can see you nodding your head there. So we all need a little bit more laughter in our lives. And I think arts and culture has a really important part to play in bringing that along with other things. And I'm sure that Daisy, although is absent at the moment, can share some amazing research and evidence around, you know, not just even partaking in arts, but also in watching the arts has an impact, a positive impact on our health and well-being and our brain health. So I'm really honoured to be here today to chair this session, which is about the social prescribing pathway. I'm co-chair of the National Social Prescribing Network. The network came into being back in 2015, my goodness, seems such a long time ago, where we were aware that there was a movement, a social movement brewing for social prescribing. And the group of people that then became the steering group and still are of the national network developed and wrote a document called Making Sense of Social Prescribing. So have a look at that. I'll see if I can pop a link in the box later in the chat. But it really highlighted the key elements to the social prescribing pathway. So some of those fundamentals that are, as we see globally now, present in most, if not all, of the social prescribing models that are evolving. And that really comes to the referrer. And in the NHS, this is not just GPs and practice staff. It is from anywhere in the community where that person pitches up with a need. We're not patients all of the time, we're residents. So from social care, from police, ambulance, DWP, housing associations, link workers can work with them at any point. So that's the first part of the pathway. The middle part, the crucial part for the NHS model is that social prescribing link worker role. And we heard earlier from Hamad about all the different names that this crucial role, this connecting role is called across the globe as well. So really important in terms of that, what matters to you conversation, that personalized approach, building trust and rapport. And then finally, the other key element, referring to a friend that's also actually on the call, Tim, there's no point having lots of travel agents if you've got no holidays to send the people to. So our link worker being the travel agent, if we have no voluntary sector, if we have no community, if we have no social capital, actually that referral out, that connecting out of our patient, of our resident, to that support is going to be really difficult and would not then fulfill our social prescribing model. So that voluntary sector at the end and the arts and culture particularly that we're talking about today. So the opportunities of people engaging in things that are going to actually support their brain health. So on to the rest of today's session. Oh, just to let you know, yes, it was Caitlin Moore from Canada. So really encourage you to have a look at this. 2022, it was establishing an internationally accepted conceptual and operational definition of social prescribing. So that's just been published literally this last month. So have a look at that. That will show you the key elements of where we are going globally with the definition of social prescribing in the pathway. But it was my pleasure and honour to now move on to our first speaker of this session. I'd like to welcome Sian Slade from Australia. She's at Melbourne University in the School of Population Health. And I'd like to pass over to her for the next few minutes. Sian.
Hi there, thanks very much for having me. Lovely to be here and lovely to see everyone and some familiar faces and some new faces. So I'll just share my slides. So you've seen this map from Hamad. Here I am, Sian, probably looking a bit tidier. It's a bit late at night here at the moment. But I'm down here in Australia. So this is Social Prescribing in Australia. It's literally a snapshot. This is Australia for those of you who may not know our island. But basically our capital is here in Canberra in the Australian Capital Territory. And then we've got states and territories and they've all got their own capital cities. So we are both a federated model and we've got states and territories and a different funding mix here. We've had an evolution of social prescribing really kicked off by Leanne Wells and the Consumer Health Forum in 2019. With a roundtable and resulting sort of recommendations. 2020 saw a couple of royal commissions in Australia and also an inquiry into social isolation and loneliness in Queensland, which Bogdan was part of representing on. And then in the last couple of years, we've had a national preventive health strategy and also a future focused primary healthcare plan. And we also have a long-term plan here, a little bit like the NHS plan. So that gives you a bit of a policy environment of where we're at in Australia, and social prescribing is mentioned throughout. However, we do not have a formal social prescribing mandate here in Australia at the moment. So what we do have is a guided coalition, and a very strong guiding coalition, both operating locally at a state level, nationally and internationally. So I wanted to talk briefly about some of the things that are happening in Australia at the moment, and these are illustrations really of the community connection, collaboration and coordination. So 3 groups I wanted to particularly highlight. ADMA, the Australian Disease Management Association, have been holding a community of practice since 2019, well over now actually 1,500 individuals, and have run 10 sessions so far. And these are really about building community. So what happens is people come on the call, they share the different initiatives they're doing, keep a sort of database of what's happening. And they're really, particularly through the COVID time, have been a great way of ensuring that the connectors are connected to be helping people that they're supporting in the communities. Building on what Bogdan said originally, so piggybacking on to the UK and also with Canada, the Social Prescribing Student Collective now operates across all the medical schools in Australia. And again, same as Bogdan also highlighted, really incorporating now allied health and expanding. One of the things they've been looking at curriculum, and I'm sure Ken Hock will mention around curriculum and social prescribing. So again, the opportunities to leverage and work with different countries. And lastly, the Royal Australian College of GPs have a special interest group in social prescribing. This is very important to us. And going back to sort of the pathway piece, Veronica, that you talked about. So we have a community and primary health care model here in Australia, which is akin really to what the experience is in the UK. Just a couple of final slides just to sort of set the scene. Was really just wanted to sort of give you a picture about there's lots of activity happening in Australia at the moment, and in fact we're at the point of, I guess, lots of pieces of activity that we really need to get to a point of formalising and scaling and coordinating these pieces. But starting in Queensland, and I'll mention again Genevieve Dingle shortly in terms of some work in the arts space and music and mental health and brain health. But working through here in terms of, for example, activities that are happening through libraries with CAMPAPSI, IPC Health have been long-standing, as have PCCS here, who are in New South Wales. And then a couple of other things to mention. So the Victorian government actually have, so I'm based in Melbourne in Victoria, have 6 pilots now operating in mental health and wellbeing in Victoria. Tasmania is the island at the bottom of Australia that you see. Lots of activity happening in a coordinated way in South Australia, the same. So lastly, I just wanted to sort of bring to a close briefly, really focusing on creative arts and particularly around sort of mental health, dementia, arts on prescription. So again, not as much activity as you have happening in the UK, but certainly many different types of activity starting to happen. Genevieve Dingle is sort of a key protagonist with this, also PCCS, Black Dog Institute, some of you may have heard of. And for me here, the Royal Melbourne Hospital have been doing a lot of work in music therapy. And I wanted to close actually with some work that's happening at Melbourne University, which is called Match. And this is a focus on music for dementia. So really in line, I guess, with the topic that we're talking about today, but really thinking about sort of different ways of being able to reach people. So I know I'm just over 5 minutes time, but I hope that gives you a snapshot of us in Australia. And any questions, feel free, folks, to come back to me.
That's absolutely super, Sean. Thank you so much. And it's really lovely to see the advances being made in the arts and culture element in those last couple of slides there. And we all have to start somewhere, don't we? And we know once we open that Pandora's box, things will start to come flooding out, and there will be some real shakers and movers and change agents out there. So it's really lovely to see that starting for you over in Melbourne. What really interests me as well is the structure is there. So that framework of the pathway, which then enables, you know, those opportunities coming up from community, from arts and cultures to fit really nicely in a coordinated way, and it's then about the funding, isn't it, which I know we're going to be talking about later. But thank you, Sean. Lovely. I'd now like to welcome from Singapore Professor Ken Hock Lee, who's Director of Office of Community Engagement and Education of the Sing Health Communities Hospitals. Now, I know you're probably still really in an excited state after your conference last week. How did it go? And we really look forward to hearing to you speak now, Ken.
Yeah, thanks. I think we really had a good time in Singapore. It's like a reunion of friends, although we are meeting for the first time. So really thank our friends from the Global Social Prescribing Alliance. Because of the conference now, social prescribing is on our national agenda. It made headlines in our newspaper, national newspaper, as well as in the news as well. So it's really a boost to the social prescribing movement in Singapore. So for today, I would like to share what we are doing in social prescribing in Singapore. A section on it that's relevant to arts and arts activity. We started social prescribing in secondary care in Singapore, and now it's spreading into primary care. And within social prescribing, some of my colleagues, the social workers and our wellbeing coordinators or link workers, realized that many of our patients enjoy art and participatory art. So we created what we call art-focused social prescribing. So largely with the help of art therapists, that was seconded to us from our National Arts Council, we were convinced of the importance of art activity in the sense that it can be an extension of reminiscence therapy. It allows our patients to express their emotion and explore meaning, and it helps them to communicate to their peers as well as to the healthcare workers. And it improves their self-esteem and confidence. They enjoy it, they feel relaxed, and it's a way for them to engage and socialize. And most important of all, we notice that it seems to preserve their cognitive function as well, which is why we think that arts actually promotes well-being. As we all know, for social prescribing, the outcome we're aiming for is actually well-being as well. So our concept is to bring the community into the hospital so that they can continue into the community in the right frame and to be connected to activities that they can continue in the community as well. So this is a sort of the 3-session program that was created. So in the first session, we have an activity called collage, where they create a collage of what they like in terms of what they like to do in life, their favorite food and their favorite activities. And in the second session is a hands-on, where we connect them to something that's happening currently in the community. Usually it's seasonal. So for right now, Christmas is coming. So our arts and crafts sessions are focused on the Christmas season. And then finally, the last session, we call it the Superpower Me session, where we ask them to create masks that represent what they wish they can have as a superpower. and then use that for engagement and for self-expression. So for the first session, we realized that it really strengthened their sense of agency. Through this collage, they were able to express themselves, what they like and what they don't like, and their sense of self as well. And during those sessions, they were able to reconnect with other people and as well as with themselves. In the second session, I think it's connecting them to the season that's happening in the community and their relatedness to the community as well. And then, of course, in the last session, I think we restore their sense of competency, put them in a mode of positive thinking and self-affirmation. So I'd like to share just two examples of what this kind of participatory art activities have, the impact that they have on our patients. So one of the patients is actually someone who was deaf since young. So he's socially isolated, he's elderly, and sometimes we assume he's a very quiet and not so sociable person. But through the collage activity, he was able to write out his feelings, the pleasure of that he has from eating his favorite food, which is noodles, his enjoyment of Kung Fu movies from Hong Kong when he was young, his appreciation of Chinese opera, and how he feels comfortable on a rainy day in the warmth of his little room looking out to the windows, and how he loves animals such as dogs and birds. Through all this, he's able to reconnect with himself and help others understand him better. So in a way, this art activity gives voice to this person who is deaf and unable to speak. And the last example, just by way of illustration, is this lady. Now, she was an independent lady, but she became ill with a chest infection, and she had a fall. She fractured her wrist, and that injury caused her to lose her confidence in her ability to take care of herself. So she was very despondent. She doesn't want to leave the hospital. She feels that she's unable to take care of herself when she leaves the hospital. And she insisted that she will not leave our hospital until we remove the cast. So our link worker connected her to this participatory art action, where she used materials to create this very beautiful artificial flowers. And at first she was very hesitant, but at the end of it, she was so proud of this piece of art that she has created, that she was going around showing this piece to other patients, to the doctors and to the therapists. And that restored her sense of self-competency and confidence, to the point that now she asked to be discharged before the cast was even off. So from these examples, we see the impact of art on people, especially people who are recently suffered a blow to their confidence and their ability to take care of themselves. And it helps them to connect with others through expression with the participatory art activity. So we are very convinced that art activity should be very much a part of social prescribing. Thank you very much.
Thank you, Keng Hot Lee. That is a really fantastic presentation. I love those two case studies at the end. It's ironic, isn't it? You know, society has never more tools to be connected, but actually it's even more easy to get disconnected, both from ourselves and those around us. And the impact of that disconnection is so challenging to our health and well-being. And yet simple activities that you've just demonstrated there can bring so much so quickly in advancement of somebody's self-esteem, their connection to others, their confidence. So thank you very much for sharing that. And it's been delightful to have you here today. So I'd now like to move on to introduce Dr. Maria Marques from Portugal. And she is from the University of Lisbon. And I think, Maria, you're going to be talking as well on behalf of Professor Sonia Diaz. Is that correct?
Yes, indeed, we have a pre-recorded video from Sonia.
It is a great pleasure to participate in this event, and I would like to thank Veronica for the kind invitation. From the beginning, we completely believe in the great benefits of social prescribing, the potential to improve well-being and physical health, to tackle social determinants of health and social needs, to offer person-centered care, to strengthen preventive care, and to bridge healthcare organizations with the third sector as well as leading to decrease in use of healthcare, reinforcing the sustainability of the Portuguese national health service. So I did not doubt that this was a strategy that we were keen to help implementing in Portugal. The social prescribing movement in Portugal started with a small local pilot project with a bottom-up approach in 2 primary healthcare units located in Lisbon. We started with the integration of a primary healthcare team and our team from Nova School of Public Health on the academic side to ensure that right from the beginning we had an approach to study and collect information that best informed the implementation, and later on we had an evaluation study design incorporated with the participatory approach and based on the context of the intervention. The social prescribing project was implemented to respond to the user's socioeconomic and emotional needs through the activation of community assets to enable them to manage their health and well-being better. This project also aimed at improving communication, articulation, and collaboration between health professionals, link workers, and social partners. Through the years and with a lot of persistence, the interest in social prescribing has been growing at local authority and policy level, and we have started working in scaling up the initiative in different regions in Portugal. From the beginning, the Nova School of Public Health has been involved in the planning and implementation, as well as in the design of evaluation frameworks which enable us to understand what works, from whom, in what circumstances, and why. And we are now supporting other teams, either from the local authorities or the health side, to implement strong social prescribing projects and scale up this initiative through the country. Indeed, social prescribing is a complex intervention. It involves multiple stakeholders as multiple models, different user types, varying aims, and a range of potential outcomes. This complexity posed challenge for the implementation as well for the evaluation and scaling up the initiative. What we are learning from the close work with teams in the field and the evaluation findings is that we could help improving the social prescribing effectiveness, uptake, and sustainability. Also, what we know so far is that for the potential of social prescribing to be achieved, it requires a collective effort of national, regional, and local authorities and multiple stakeholders. To conclude, I want to mention that Nova School of Public Health created Social Prescribing Portugal with the mission of strengthening the research, implementation, and dissemination of the initiative in Portugal. Furthermore, Social Prescribing Portugal includes a team of members of the academic community, the health sector, and the social sector, which has participated in several events in public health, health promotion, and integrated care to promote social prescribing. The team are also developing training for health and social professionals to support its implementation in Portugal. So we are very much committed to social prescribing at national, but also international level. Thank you for your attention.
And I will share also my presentation. First of all, thank you for the invitation. It's a real pleasure to be with you today in this exciting webinar under this lovely partnership between the Global Social Prescribing Alliance and Arts for Dementia. I'm going to briefly share some slides with some of the insights of our pilot experience of social prescribing in Portugal. From the beginning of social prescribing, the Nova Public Health School in Portugal has been involved in the planning, implementation, and also in the design of the evaluation framework. The social prescribing in Portugal is really in his early steps compared to the experiences that you've previously shared. So it started in the end of 2018 in 2 primary healthcare units in Lisbon, the Portuguese capital, and the movement started with a small local pilot project in a bottom-up approach. And since 2020, the interest of social prescribing has been growing at local authority and policy level. So in the Portuguese context, the social workers, mostly based in community-based organizations or even public entities, play the role of link workers and receive the referrals from the GPs, the general practitioners. So the social prescribing model implemented into health units in Lisbon is really comprehensive with regard to the criteria for referral, including patients of all age groups and with non-clinical needs enrolled in these units. So just to give you a flavor, these units are in downtown of Lisbon, and they are really public primary healthcare centers linked to the Portuguese National Health Service, which provides general healthcare to all age groups of the population enrolled in these units. In this case, approximately 28,000 people. And the population assisted by these units is composed of people experiencing vulnerabilities, such as seniors in isolation, recently arrived migrants, people with low education and unemployed and homeless. So again, it's really in its early steps, but taking a quick look at the first 40 months of the social prescribing, around 700 referrals were made. In terms of the user's characteristics, approximately 70% are women, around 40% with more than 65 years old, and most with at least one chronic condition. Here we can see clearly that the most frequent chronic conditions were cardiovascular diseases, mental health, obesity. Also around 40%, a significant number, were from migrant backgrounds. So the main social needs identified were access to social benefits, social isolation, and mental health. And this is really important because we know more than ever that both social isolation and cognitive inactivity are risk factors towards people developing cognitive decline, especially as they grow older. We were able to explore the barriers and facilitators regarding the implementation process. So we conducted interviews with general practitioners, social workers, social partners, and all the stakeholders interviewed highlighted as factors that really facilitated the implementation, the characteristics of professionals, the frequent and dynamic communication, the proximity to the community, and the physical presence of link workers in health services. But also a lot of barriers still, mainly issues related to funding, human resources, time availability, and users' perceptions of the interventions were really the main barriers. So in Portugal, the general practitioners makes the referral to the link worker, for instance, to preserve their brain health. And the link workers carry out an assessment of the user's needs. And this is really important, but also their strengths and preferences. Not only from an individual approach, but also the family approach. And they seek responses in the services available in the community. So in Portugal, the social prescribing model is really embedded in community settings. And here we must acknowledge the efforts conducted by the link workers and all the partners to map out not only the formal services and resources available, but they really look into the informal resources that are available and not so well known, namely in what concerns the arts. So we know that it's fundamentally important for people to retain meaning, but also purpose and general well-being, and arts-based processes and activities are key in achieving this, alongside with the more traditional and, of course, medical approaches. And what we are finding is that the arts are really transformative and can really have a positive impact on cognition, attention, stimulation, enhanced communication, engagement. So the link workers are really investing in making arts-based activities accessible to the users of social prescribing. And here the important thing is not only to stimulate the mind, but also to create a social experience, impacting both at the individual, but also the community levels. Just to give you an idea, these pilot experiences started in the Lisbon downtown, one of the most multicultural neighborhoods in Portuguese capital. You have seniors isolated in ancient buildings without elevators, really isolated, living side by side with recently arrived migrants. Most of them don't speak Portuguese language. Just to give you an idea, more than 30% of the residents are migrants with 50 nationalities living together. So here we have some of the arts initiatives included in the referrals from the link workers. We have from the most traditional arts activities up to the most innovative, such as the photo voice, engaging people from different backgrounds that really can share their experiences and narratives through the power of the photographs. But here the challenge is really motivating the participants, namely the ones with mild cognitive impairment and potentially dementia or other mental challenges, to participate and come to the appointments with link workers. Here, having link workers who are based in community organizations and that really know well the communities, and sometimes going to their homes is really key. We also know that, unfortunately, there is still a fundamental disconnect between how we develop initiatives, including in the arts, and the way they are received by the members of the community, by the users. As a result of this disconnect, when we evaluate how effective interventions are, we find that they are often weak, not scalable at all, and don't even seek to reach segments of the population, because many initiatives are designed for what we call the Miss or Mr. Average, and therefore many people are still left behind. And this disconnect comes really from no inclusion of the users in the co-design of the arts initiatives and how they are implemented. Here, just to finalize, we were able, during the pandemic, with all the lockdowns, still to carry on some arts initiatives. Here we have the example of a virtual photo voice initiative, where we were able to engage different users, online participation, to take pictures or design and to share their images and their experiences in group discussions, online group discussions. So it was really important also to engage the users from the set of this initiative, in the design of the initiative and in the implementation. So the interest of the social prescribing has been growing in Portugal, and we have started working on the scaling up of the initiative in different regions in Portugal. So thank you again for this collective effort and for all this passion shared here today. Thank you again.
Great, thank you so much, Maria. Just a couple of really important reflections there. Firstly was the interest in health inequalities and the support to migrants. I was particularly interested as well when you showed the slide about museums. Obviously, this isn't just about arts as in theatre and cinema and other active arts, it's also about museums. And you mentioned volunteers. Now we know volunteering, the evidence is volunteers live longer and happier lives, just up to 5 years longer. So that volunteering. And the final bit that really caught me, Maria, was about that asset base. So it's not a determination of the link worker or a GP or a social worker or a connector as to what that person needs. It's actually what they bring. What are their assets? And that's the what matters to you conversation. What is it that you can have, that you do already, that you enjoy, as well as filling the gap that is in their lives at the present time. So those were my observations. I'd like to thank Sian, Keng and Maria for you sharing your stories of the pathway across the globe. I know we're going to go a bit further, so it's a whistle-stop tour today. Really appreciate your time, particularly being out of the time zone significantly. And I'd love to pass back to Veronica to take the session forward again. Thank you, everyone.
Thank you, Sian. It's all been so fascinating that so thank you, Sian, for your totally brilliant sharing, all the speakers for your inspiration. And may I now introduce Alexandra Coulter, who has done so much for culture, health and wellbeing, and is director of the National Centre for Creative Health, to take forward the arts prescription panel. Thank you, Alex.
Thank you, Veronica. Thank you very much for asking me to chair this section. We've been hearing about the context of social prescribing globally and in individual countries and projects, and we're now honing in on the arts on prescription pathway. As Michael said at the beginning, people have been doing this kind of work for a long time, and certainly in the arts, arts on prescription has been well established in pockets across England, I would say. But it's with the commitment from NHS England in the long-term plan and the establishment of all the link workers around the country that everything has grown so exponentially. And so it's really fascinating to hear now from some 3 further countries. We have Italy, Austria and Canada, about what they've been doing, how they've been working with the arts in social prescribing in their communities. So first of all, we have Maddalena Ilario from the Department of Public Health Research and Development Unit at the Federico University and Hospital in Naples. Over to you, Maddalena.
Thank you so much for the invitation to join this inspiring initiative, because I am rather new to the social prescribing field, but I feel this community is open and warmly welcomes newcomers. So so this is to say that Italy is there is a movement in Italy also, and there is a growing awareness respect to the impact of social prescribing, especially on loneliness and social isolation. And this has been paralleled by an increase also at the volunteer sector that plays a key role, as we heard from previous speakers, especially Maria, the role that volunteers play in providing valuable services to bridge the gap for social innovation and integrating and addressing other needs of our patients. And this growth has been especially concerning southern regions. Indeed, my region, that is Campania, has seen an increase by 4% in the social sector. Mostly social prescription of social services relate in Italy high complexity patients' needs and are carefully regulated by the national agency and the Ministry of Health. But currently there has been an effort in improving the integration of digital solutions and innovative approaches into strengthening social services integration through organizational guidelines and taking advantage of recently appointed National Resilience and Recovery Plan funding. So this is there is a paradigmatic shift from reactive disease management towards person-centered and innovative approaches to health that brought us outside the traditional settings for healthcare service provision. And health promotion can be also deployed by pilot initiatives inside theaters, as we also heard about the effectiveness of music therapy and thermal spas. So this means also that we need to take into account the socio-cultural elements that drive behaviors in humans, and this is also the reason why there has been a strong engagement of the Ministry of Health in health promotion activities through the National Plan for Disease Prevention that has been supported by initiatives such as the online database on good practices for health promotion, and there has also been an effort of the regions in receiving these plans. And in Campania, for example, there has been health promotion guidelines that are driving the initiatives of the local health agencies in health promotion, engaging with the communities of volunteers. There is also a new initiative of the DOORS that is an executive master focusing on healthy aging and chronic diseases, and which role there can be for culture and cultural valuable initiatives. There are growing initiatives on the ground, like Health Campus, that is being replicated in many cities throughout Italy, where a number of professionals from the healthcare sector have been stimulating the engagement of local volunteers beyond the health professional sectors in reaching out citizens in the streets and involving them in building their digital and health competencies. And we have been also involved in one project that has been pioneering the community engagement to prevent frailty in older adults. And in this project, we have been implementing rather successfully, I would say, an education package that was built on the empowerment of older adults and for digital and ICT literacy. And the activities that we were deploying included also cultural and arts activity. And although it was a ICT-driven societal innovation project, it was showing, we are clinicians, so we were measuring the impact of this, although we were not providing clinical services per se, we were measuring the impact. And one of the tools we used for measuring was provided by a colleague from Ireland, the Professor William Molloy and colleague Ronan O'Cahoin, and was a very sensitive and specific tool to measure mild cognitive impairment. And we could measure that the impact on cognitive functioning of all these activities together that were targeting food and nutrition, physical activity, socialization, were improving cognitive functioning significantly. We then validated the tool in Italian, and now we are currently further developing the exploitation of this kind of activity. I will show you next slide. In the meantime, what we decided to do while the project was being deployed was measuring the impact of social and cultural engagement on dieting and well-being and resilience in a group of residents in the periphery of Naples. And we could measure, basically, the target group was had a subscription to a local theater. So they were engaged in the plays, and we could measure that considering BMI, adherence to diet, and perceived well-being, and also inappropriate access to clinical services were significantly different between the two groups. So currently we are trying to bring this all together into a national study that will start next week. So I'm very, this meeting is very timely. And this study is exploiting the result of a previous European project that is called Sanfrail, and developed a 9 items questionnaire, very simple. Also non-health professional can deploy and administer this very simple questionnaire to identify the domains, health domains at risk for older adults in this case, to link to further assessment that are more detailed and specifically in this case, we can focus on the cognitive decline and the quick mild cognitive impairment tool to identify health promotion activities that can concur synergically to improve health outcomes for these older adults, preventing disability and dependency, and also delaying the onset of dementia. Now, what's the problem? The usual problem that has also been referred is sustainability. So we know by fact that sustainability strategies for health services include disease prevention, health promotion, reduction of inequalities, and addressing vulnerable people needs. But nonetheless, we still keep investing less than 3% in these activities. And now we also know that innovative good practices that are digitally supported can help implementing personalized approaches to health promotion strategies, if we just think about all the mobile health solutions. So here there is a room to strengthen investment and include these kind of services in the social prescription framework. So this is something we cannot do by ourselves, and we have been working in a huge effort to build communities, local communities that are innovation ecosystems. So we try to bring together government organization, academy, research and industry, and patients and citizen society through European reference sites. And there is a network that is European reference site community that supports local communities to develop and exchange good practices. So I hope that we can contribute to further develop this community of social prescribing in our community, helping to conjugate innovative approaches, mobile health and digital solution with social prescribing. Thank you.
Madalena, there was so much in that I would like to find out more about that real focus in the measurement, so we're really understanding what's actually happening in different activities and the use of digital and this whole issue around investment. Lots of fantastic stuff there. So I'm going to move on to Edith Wolf-Perez, who's Director of Arts and Health Austria. Edith?
Yes, hello. Thank you very much. I mean, I'm so inspired by this session that I feel like the baby in the room, because Arts for Health in Austria and social prescribing are really new. Not that there are not many activities, but to bring them together is the challenge. I'm just sharing my slides. So we had the first pilot in 2021 for 6 months. It was the UK served as a role model. So also in Austria, the link workers played a central role. The aim of the project pilot was to generate implementation experience and to build on this, to develop a professional basis to implement social prescribing for sustainable on a sustainable level in Austria. The pilot was launched and funded by the Ministry of Health and Social Services, because it meets two of the health goals of the ministry, which is prevention and health promotion. Out of 17 applications to the call, 9 primary care centers were chosen, and they were chosen for diversity. So that they made sure, that panel made sure that there are rural and urban primary care centers, that special target groups were addressed, and that long-established facilities as well as emerging centers were included. During the 6 months, 178 patients took part in the social prescribing scheme, and the main target groups were people with migration background, the uninsured, single people, and elderly people. The most common reason for social prescribing for transfers were social or emotional needs, health promotion and prevention, no social network or other support, and signs of overstress and anxiety. So I think this corresponds to the general picture in globally. Regarding the arts and culture, I would like to mention an initiative in Graz where extra funding came from the local government for theater tickets. Now, they met two goals with that. First of all, they supported the social prescribing scheme, but also they supported the local theater, because after the pandemic, you know that theaters are really fighting to get the audiences back. So the theater in Graz invited the link workers to sensitize them into their program, and then 10 patients took up the offer and visited theater events. It was made sure that they don't come alone, that they bring a companion, so that they have a social exchange, that they can discuss it. There were also discussion groups offered to the visitors, and some of the patients and some of the visitors also joined in there. The evaluation of the first pilot showed that it was a success story. The link in the facilities, link working could be established. It was really working well. Disadvantaged groups could be reached. Improvements was assessed in mental health, 16%, social networking, health literacy, and future prospects. So, and the acceptance rate was quite incredible. 100% would recommend social prescribing of the participants. Based on this acceptance, there is a second call out now, which will start in February 23 and 24. The Ministry of Health is funding it with 560,000 euro. And if you compare it to the first pilot, that was only 6 months, now it's 18 months. The money was 300,000 for the first pilot for 6 months, it's now 560,000 for the second pilot. I wonder whether they all underestimated the economic benefits of social prescribing in the first call, because the reduction of the budget indicates that there was money left over. I haven't been able to find out the exact reasons why this was handled like that. In the meantime, there are resources available. So the evaluation is done scientifically by an agency that is connected to the Ministry of Health. And they provide quality assurance measures, they provide training for link workers. There's now also in the BA for social workers, link working is part of the curriculum at the University of Applied Social Sciences. There is a standardized documentation and an evaluation. Networking meetings have led to an exchange of experiences, and from there a handbook was produced. So these are really the prerequisites to make a sustainable implementation. I introduced shortly, I talked about theater on prescription, but as we have heard during the day, to participating in arts activities on a regular basis is actually much more beneficial, especially for elderly people, and preventing of cognitive decline. Now, there are many initiatives and arts initiatives to address this topic, but they are not connected. They are not in the local network. So the next step for arts and culture would actually be to raise awareness about the role of the arts for health and well-being, motivate local arts organizations to get active and provide offers within the social prescription module, and create an Arts for Health network on the local level, on the regional level, and nationally, and of course, internationally. So this is the first steps for social prescribing in Austria. Thank you very much. Arts for Health Austria is trying to promote social prescribing very much in their goals. Thank you.
Thank you, Edith. And very interesting how those priorities from health, we're seeing that across all of the presentations around person-centered care, prevention, promotion, and very interesting to hear about the challenge of integrating the arts and cultural ecosystem, which is obviously there separately from social prescribing, and how that can be integrated into social prescribing, which I think is also a challenge here. So we're now going to go to Canada, and we have Sonia Shung, Director of the Canadian Institute for Social Prescribing, and Melissa Smith, Programme Curator of Collaborative Learning, Art Gallery of Ontario, Canada. And I think you're both going to speak for 5 minutes each. So I'll hand over to you both now. Thanks.
Great, thank you. It's a pleasure to be here. So my colleague Melissa and I are joining you from Toronto, Canada, which is the traditional lands of the Mississaugas of the Credit, Anishinaabe, the Haudenosaunee, and the Wendat peoples. An important context for the work that we do in social prescribing and otherwise is the continued inequities faced by our Indigenous communities, and we hold very closely our responsibilities to work towards reconciliation. Now, for those who might not be familiar with our country, Canada is comprised of 10 provinces and 3 territories. So many of our structures, including our health and social care systems, are provincially governed. So each province organizes healthcare in a different way. Canada is also vast geographically, so that means the challenges in each community facing and the resources that are available within each region is quite different. So there are a number of social prescribing initiatives being implemented in various regions that you see on this map with different types of investments. So in BC, British Columbia, which is those red dots that you see on the map, social prescribing is funded by the Ministry of Health as a demonstrative project and being led by community-based organizations. In Alberta, with the black dots, the initiatives are being funded by a private foundation, as well as the Ministry of Seniors and Housing. In Ontario, with the green dots, there's a large collection. There are different models that are emerging from hospitals, older adult centers, home care organizations, pediatric hubs, and others. And the largest number of initiatives are located within the comprehensive primary healthcare sector in a type of model we call community health centers, which is primary healthcare co-located with allied health professionals, community programming, and community development workers. These initiatives are funded by private philanthropy, as well as partnership with organizations like the Art Gallery of Ontario. So I think you get the picture here that while we have very strong momentum, all of our initiatives are regional, they're time limited by funding and ad hoc. So unlike the UK, and I think some of the other places that's been mentioned, we don't have a system-wide investment into this type of practice anywhere. And this also means that engagement with arts and cultural organizations in particular, and the pathway to connect people to arts-based interventions are highly dependent on the region, on the specific project funding, and on organizational specific initiatives. So this is probably why we have formed the Canadian Institute for Social Prescribing as a national hub with the aim of connecting people, the practices, the projects, and the research across different sectors together under one big network so that we can learn from each other and collaborate and celebrate what everyone is doing in a way that is grounded in our commitment to equity, to community leadership, and to collaboration. And we're intentionally right now bringing together key stakeholders to co-create a national framework for social prescribing for us in Canada that has shared principles and values, but is adaptable to our unique context and assets in the different communities. And we bring together communities of interest around advancing clinical practice, research, policy, and knowledge mobilization. And we hope that together we can build the momentum for policy and practice change in our country. And so we're forming that foundation together with multi-sectoral partners and participants. And they include organizations that have a national mandate. Those are focused on specific underserved populations in Canada. And we also have a Canadian social prescribing student collective that's moving the knowledge and practice forward in education with their peers. The Art Gallery of Ontario, under the leadership of Melissa Smith, is one of our key arts partners in the Canadian social prescribing landscape. And I'll pass it to her to speak more about the arts, culture, and wellbeing community practice and the pathways to the arts with the principles of equity and co-creation, what that looks like in practice, and how her and her colleagues are pushing to make what they do more standardized across Canada. So over to you, Melissa.
Thank you, Sonia. And just really a pleasure to be here to share what we're working on and to hear from so many wonderful folks. But I guess I'll start by just establishing that I'm one of the co-chairs of the Arts, Culture and Wellbeing National Community of Practice, which really originated as an informal group for local Toronto arts and culture workers and healthcare professionals to connect. And Rachel Robbins, an arts psychotherapy student, former director of education engagement at TO Live, and Vanessa Smith, manager of education outreach at the Corporation of Roy Thompson Hall and Massey Hall, are my fellow co-chairs. And over the past several years, as we've adapted to many changes in our industries, both arts and healthcare, we now operate in connection with the Canadian Institute for Social Prescribing, and we serve as a national hub to connect people with aligned interest in social prescribing and well-being, specifically in relation to arts and culture. We also connect with an organization called the Alliance for Healthier Communities, which supports community health centers, so the not-for-profit organizations that provide primary health and health promotion programs for individuals, families, and communities. And we collect our programs and site information to share with community health centers, raising awareness. So picking up from where we've heard some of our speakers address things before. And so today I'm going to share how this work manifests by describing a case study and how pathways manifest in Canada in this sort of liminal stage while we build a formal model. So I work at the Art Gallery of Ontario. You can see our lovely photo there. The architecture is by Frank Gehry, and we're located in downtown Toronto, which is Mississauga territory and also governed by a treaty between the Mississaugas of the Credit and the Canadian government. And again, this is very important for us to acknowledge as a colonial country. So the Art Gallery of Ontario is one of the largest art museums in North America, attracting approximately 1 million visitors annually. We have a collection of over 120,000 artworks that ranges from Indigenous and Canadian to European, and we often mount special exhibitions. Our mission is to really lead global conversations from Toronto through extraordinary collections, exhibitions, and programs, and by reflecting the people who live here. And our core values are art, audience, and learning. I am part of the Education and Programming Division, and we really try to generate meaningful, experimental, and inclusive experiences connecting people, art, and contemporary ideas. And to just kind of narrow down now too, we create access and pathways to the AGO through our community and neighborhood memberships. So organizations serving marginalized individuals can provide their clients with free visits. But the work I do is very much about curating the AGO's access to art through a suite of programs, exhibitions, and installations that support visitors with perceived or physical barriers to the AGO. And you can definitely see a range of those programs at the Access to Art page that I'm just about to put into the chat, and we're just in the midst of updating all of our programming for the 2023. So we believe that programming beyond providing tickets is key to supporting social prescribing and access to art. So I'm just going to share a little mini case study of how we can do that work. And it's really by sort of inspired by facilitating peer-to-peer relationships. So with the South Riverdale Community Health Center and the AGO as service organizations, we decided to remove the authoritative role of the museum or health center and prioritize a peer-to-peer co-designed experience at the AGO, kind of riffing off of the person-centered care. And South Riverdale offers a range of programs that are peer-led and inspire people to play an active role in their health and well-being. So the peer program is made up of members of the community who have lived experience with chronic illness, pain, or disability who are paid for their work. The paid peers learn to practice core self-management skills such as goal setting, decision-making, problem-solving, emotional management of symptoms as an integral part of their clinical journey. And to combat perceived and physical barriers to the AGO, peers are involved in the program development. So the co-design approach ensured that peers informed the program based on lived experience, saw themselves as integral to service design, and valued their role as stakeholders in the services offered in the partnership. This is also a way we work to help deconstruct the colonial systems that are inherent in a museum and espouse the disability tenet of nothing for us without us. As a group, we decided to focus on gallery tours and offsite art making workshops at the community center, which were offered based on a training workshop and toolkit that the AGO produced to help support this work. And we found this was a successful way to encourage confidence with visiting the AGO and continuing the experience via art making back back on the home turf of the community health center. Over a 3-year period, we had 85 active repeat participants, and we worked in an iterative process, hosted focus groups to inform the evolution of the program and evaluation. And just some quick qualitative feedback was I enjoyed myself, I felt calm and relaxed. The group facilitator helped me feel dignified and respected, and the group facilitator helped me feel comfortable at the gallery. And this was really important because during focus groups previous to this, we found that actually one of the #1 things that people say about having barriers to the gallery is not feeling they need to know about art history. They also say that sometimes they don't see themselves reflected in the collection. And also the one that kind of breaks my heart the most, that they don't know what to wear. So there are really these perceived barriers as much as physical ones. So then during the pandemic, we shifted. So I just wanted to acknowledge this, and we transitioned to a monthly 1-hour meeting style Zoom, where it was offered by an art educator and an art instructor, so a tour in art making. And between April 2021 and March 2022, we served 552 participants during the live events and 5,127 in the asynchronous recording available on the website and Facebook. As an online program, we noticed a wider provincial reach, particularly for rural communities, health centers, who were really recommending the program as a form of social prescription in a sort of a grassroots way. And really all of this programming is supported operationally at the AGO. We are funded by 1/3 of the provincial government, so the Ministry of Tourism, Culture and Sport, so one-stop shop really for that ministry, and 1/3 by box office sales, 1/3 by donors and sponsors, and the last little bit is by granting bodies and foundations. So none of that funding is specifically earmarked for accessibility or social prescribing, so this is also the work that I do within my portfolio. And finally, so by co-designing processes that are determined by people who are using the services, we found that we've promoted agency and created inclusive spaces and access for people who otherwise might not have considered or experienced the well-being benefits of cultural spaces like the AGO. And in addition, the Arts, Culture and Wellbeing National Community of Practice is collectively trying to move the arts sector towards health arts partnerships like this one, and are supporting CIS, or Canadian Institute for Social Prescribing, in a wider policy and systems change work. So thank you everybody for hearing us out today.
Thank you very much, Sonia and Melissa. That was fantastic. It's so inspiring to hear what's going on around the world. And interestingly, all of you 3 presenters did lead us into the next session, which is around sustainability and funding. So thank you very, very much, everyone. I'll hand back to Veronica to introduce the next session.
Thank you so much, Alex. That was absolutely brilliant, and fabulous speakers too. We're so lucky to have Alex, who is fount of all knowledge on culture, health and well-being, to chair your terrific talks. So many, many thanks. And I should now, yes, what we all terribly need, like to introduce you to Tim and Philogov to chair the funding and solve our problems. Yes. Sustainable arts prescription models for funding. Thank you.
Thanks very much, Veronica, and what a privilege it is to be here. I was thinking, as mentioned, of 2016 when I was in the room when the English social prescribing movement really kicked off. I've also had the privilege of going to Ontario, where I worked with Sonia back in, I think, 2018. To see the progress that's been made internationally is just so exciting. We've got the poison chalice, which is to try and talk about funding. I'm going to just set the other 3 speakers in a bit of context in terms of where we are in England. Since July, we've had something in England called the Integrated Care Systems, and that's a mixture, it's a partnership between the NHS and, in our case, in Hertfordshire and West Essex, 15 local authorities, and a partnership of many, many voluntary organisations, which is called the VCFSE Alliance. And this is something that each new ICS is meant to have. And it's really important as part of creating a real partnership with the voluntary sector. Now, there isn't a silver bullet here, and Joshua will be talking about the model with thriving communities. But there is some research that's been done about the different models of funding in England. I've put that in the chat. But one of the things that comes out of that research is a clear message that it's having all the stakeholders working together that gives you the best chance of coming up with sustainable funding. And on that point, I think it's really important that ICSs in England are driving a vision about the role of the voluntary sector as a whole in addressing the wider determinants of health. And one example I could give you is Bradford, where they're actually working as a system to try and shift 1% of the overall funding for health and social care into the voluntary sector. So away from putting out fires, if you like, to the sort of work people have been talking about today, and preventing fires happening from in the first place, and people getting sick because they're lonely or whatever. And next to all of this, I think it's really important that we talk about the data that we're starting to get better at collecting. In particular, we can show that our social prescribing in Hertfordshire is reaching the 3% of the population who are in the most deprived fifth in England. And we're doing that much more than we're reaching other bits of the population. So clear focus on deprivation, and also clear evidence that we're improving the life satisfaction and happiness of our citizens according to the ONS4 scale that we use, and reducing their feelings of anxiety. So that's not all about arts on prescription, but some of that will be about arts on prescription. And just to stress the importance of that VCFSE Alliance, in our ICS, we're working together with them on a health creation strategy, looking specifically at those aspects of health where the voluntary sector can make all the difference. I'd like to introduce Chris Easton now, who's going to talk about the same set of principles, really, both from his NHS Charities role, but also his experience working in the NHS in Manchester. And I think Veronica's going to magically make that happen.
Nigel.
So good afternoon, everybody, and sorry that I'm not able to join you live today. My name's Chris Easton. I work as Director of Strategy and Impact for NHS Charities Together, who works alongside the Arts Council on the NASP Thriving Communities programme supporting social prescribing. I've been with NHS Charities Together a couple of months now, but prior to joining the charity, I spent 10 years in the NHS, initially working in national policy and then subsequently locally within an integrated healthcare system in Manchester. One of the many things we did during that time in Manchester was commission what was at the time one of the largest social prescribing programmes in the country in 2016. A time that predated the onset of link workers working within primary care networks, and the programme that we delivered worked with over 2,500 people per year. What was really interesting about social prescribing for me during that time was the impact that it has on people's lives, the improvements in people's well-being, both in a quantifiable, measurable sense, but also in an anecdotal sense, was quite incredible. And the other thing we were able to do is to evidence that not only did social prescribing have an extremely positive impact on individuals' lives, but it was also able to reduce activity in the health and care system, particularly in unplanned activity. So we were able to demonstrate around about a 40% reduction in general practice activity for those people who were referred into a social prescribing programme versus those who were thought to be in a position to benefit but opted not to take up the referral. So really significant in terms of the impact that such programmes can have on the system. A key part of the success that we achieved in Manchester was founded on the basis and founded on the recognition that the voluntary sector plays a vital role in social prescribing. You can't develop programmes as local health and care systems that drive activity to the voluntary and community sector without first thinking about how that infrastructure is to be sustained and funded. So prior to joining you today, I wanted to give a little bit of thought to some of the key elements that for me are critical to sustainable funding approaches in the voluntary and community sector. Firstly, we need to understand and believe in the impact that the social determinants of health have on both planned and unplanned activity in the NHS. It's really, really significant. And if we think about the volume of activity that's generated from a social context, this provides the evidence rationale for approaches such as social prescribing. It's important locally that we invest in infrastructure. So the voluntary sector can unlock all sorts of funding and opportunity that supports people in ways that the health and care system simply cannot. But many of these organisations, many of them are very, very small. Many of them need the kind of support that infrastructure organisations provide within localities. It's really important that we recognise the diversity of the sector and foster it. You know, not all voluntary sector providers are large. Many are micro organisations run entirely on volunteers with income of only a few £1,000s. Yet actually, some of these organisations can provide support to individuals that is so incredibly valuable. It's important that the public sector uses its spending power to bolster the voluntary and community sector. You know, we have an inherent value in there is an inherent value rather in having a vibrant and diverse voluntary community sector within our localities. Yet too often it's not something we prioritise investing in within the public sector, and often it's fair to say that we treat the voluntary sector a bit poorly in the way in which we might commission or fund services. And finally, evidencing impact effectively. The potential of programs like social prescribing that tap into the things that drive ill health and subsequently activity within the health and care system are absolutely integral to the future viability of the health and care system. Without tackling the drivers of demand, it becomes virtually impossible to meet the rising demand that faces the system. Thank you very much.
Thank you very much.
And as I mentioned, and Chris's points there really about the importance of the evidence, being able to demonstrate why this should be funded, and that vision around the wider determinants and the value of the voluntary sector, absolutely crucial. And it's been part of why we've recently managed to convince the NHS to put £500,000 this winter into money advice, because of all the people who might otherwise end up not being able to turn on their heating and ending up in hospital. The next speaker is Mags from the Arts Council in England, and perhaps we'll be speaking a bit more about the arts aspect than so far we've spoken about in this session. Over to you, Mags.
Thanks, Tim. It was very kind of Veronica to say to me as we were preparing for this session that she felt our creative health plan was it deserved the term best practice. But it doesn't sometimes feel like that to me, and I'd rather like to suggest that where we are feels very much like work in progress, and I think a learning mindset and an openness to new ideas is going to help us make that progress. But to give colleagues from abroad some context, the Arts Council is the national development agency for arts and culture in England, and we invest about £600 million a year of tax and lottery income, and of course that's a reasonable sum of money, but it's never enough, especially to match our ambition in creative health. So we've undergone a strategic shift in the last few years with Let's Create, our 10-year strategy focused on the public benefit of high quality arts and culture and communities. And this strategy has informed the development of that creative health plan. And I think Veronica's focus on fostering well-being implied by that concept of brain health is an important starting point for us as well. I feel that this broad space of stronger, happier creative communities is where there are enormous gains to be made. And I want at this point to say that this plan didn't really come from the Arts Council. It came from practitioners and from talking and listening deeply with the public. So the fact I'm talking about this today is a tribute to the efforts of many people in this room. So I think from where I sit, I see this all as a rather complicated jigsaw in which we are a strategic partner. But of course, jigsaws have a deeply satisfying payoff in terms of providing a practical outcome. So let me talk you through the pieces we place in the jigsaw. There's, as I've mentioned, there's our 10-year strategy, Let's Create, and that's directly informed our plan for creative health and wellbeing, which we published earlier this year. Excuse me. And together they lead to a position where creative health is a fundamental part of living well for communities and globally. And the plan directs us to tap into a set of shared priorities across funders and the health and social care sector. And it also directs us to widening engagement with creativity and culture, with a particular focus on those who experience barriers to access and supported and informed by data on health inequality. And this way of working represents a really fundamental shift away from health projects as additional activity towards viewing health and wellbeing as germane to the cultural sector's purpose. So the plan itself is built around 3 jigsaw pieces of partnerships, place and practitioners. And I was asked to give you really practical examples about how that translates, I suppose. So if I start with partnership, I'd obviously point to how we've grown our relationship with the National Academy as absolutely critical to progress. And recently we've invested in a arts and culture leader at the Academy, which will help us ensure that the arts is a core part of our shared thinking and to connect the cultural sector to social prescribing strategically. And it sits alongside similar posts funded for sport, nature, financial advice, etc. And I think this will help us in that engagement with national level structures and network to foster growth. In terms of practitioners, I'm delighted that we're continuing to offer support to the Creative Health and Wellbeing Alliance, who we've recently announced will be part of our national portfolio of funded organisations through to 2026. And we support them as a network and membership organisation, connecting arts and health practitioners across England and providing resources and developing best practice in this field. And on place, this feels like an absolutely critical area of development for us in the coming year. As an example of that, one of the things we've been doing is deepening our partnership with the National Centre for Creative Health and having conversations with them about the potential of investment in regional connectors to link NHS regions with the creative sector. And I think as the Arts Council itself is making the changes to its own ways of working to adapt to orientate to our new strategy, I think we need that support on the ground in place to make things happen. This would help us with essential place-based engagement to foster structures and networks. We do need to bring the Arts Council and our sector into conversations with the NHS through ICS structures, as we already naturally do through very long established links with local authorities. I also want to emphasise the role of libraries around place, and our as a development agency for libraries, rather than the direct statutory funder, we want to develop their role as critical community hubs. And of course, they already exist in every community, free to enter, and are just wonderful things. I think as an example of things we've done there, we've shifted the focus of our project grants to reflect that we want to support the health and wellbeing offer that we hope to see grow in libraries over time. I know Joshua is going to speak about thriving communities, in which we, another key project around place in which we were a partner. And there's a lot to learn from that programme about working in place. But for me, the big structural challenge is how we're going to establish those place-based links and bridges alongside the national relationships, which now start to feel more secure and stronger. I just quickly want to finish by mentioning what really matters to the public, which is the art. Our shift as a funding body in our strategic orientation really makes a difference to how we invest. So, for example, investment in arts and health has increased threefold via our National Lottery project grants since the Arts, Health and Wellbeing APG landmark report urged us to do more in 2018. And we've also increased the number of organisations doing work in the new national portfolio that I previously mentioned that we announced in November. So So that's a whole range of exciting new organisations, as well as established icons that we are supporting. So we have the Wigmore Hall addressing young onset dementia, or new organisations like Magic Me in East London, bringing the young and old together for creative projects, or Still Curious, a project in South East England offering memory walks and curiosity cafes for older people. So, as I say, I think there's a lot of work for us to do, a lot of exciting development for us to engage in, but I think that jigsaw I referred to, it feels like some of the pieces are now slotting into place.
Thanks so much, Mags. And the metaphor of the jigsaw, really helpful one, I think. And I think that Josh is going to pick up on that whole set of principles, really, when he talks about thriving communities next. And if you want to talk about the NHS, I'll be very happy to talk to you as well, by the way. Josh.
Thanks very much, Tim. Good afternoon, and thanks so much to all the inspiring speakers we've had today. It always warms my heart to see the passion and dedication and knowledge and skill of my fellow colleagues in social prescribing. So my name is Joshua Ryan, and I'm the head of the Thriving Communities programme at the National Academy of Social Prescribing. The Thriving Communities programme itself exists to support the VC FSE sector in delivering social prescribing activities, whilst also developing sustainability and resilience in these uniquely challenging times. We do this through a coordinated, cross-sector and collaborative approach to peer-to-peer learning, amplifying best practice, webinars, building networks, and encouraging and enabling place-based cooperation. We believe that connected communities are thriving communities. And if, like Mags said, social prescribing is a jigsaw, then thriving communities is here to show people what the picture on the front of the box actually looks like. And one of the ways we've enabled social prescribing activities to thrive at a place-based level was through our Thriving Communities Fund. You would have heard a little about it already today. And now this was jointly delivered with Arts Council England and our numerous other partners. And it was a £1.8 million fund designed to encourage cross-sector collaborative working at a place-based level. Now, 37 of these projects were funded, working across a range of target communities, such as people living with dementia, homeless people, asylum seekers, unpaid carers, and ethnically diverse communities. And we believe that this collaborative approach, this whole community approach, is crucial to securing sustainable funding. For this fund, a year-long evaluation was carried out, a few highlights being that over 11,000 people were supported by projects attached to this fund, and 80% of all referrals were attended. Approximately £1 million in supplementary funding was leveraged by this approach, showing just how much this model is attractive to investors and develops the sustainability of the organisations involved. Feedback from the organisations themselves said that it built the confidence to use local assets. It gave experience of maintaining partnerships between organisations at a local level, and it also built the social prescribing infrastructure within region and developed strong links into the health system. Now, the full evaluation link can be found on our website and can be shared after this meeting as well. But to me, personally, the most important outcome is a quote from one of our participants who said, to me, you have all been so supportive, gentle. It was so lovely. I feel like I'm being listened to and understood. There is help there and there is hope there. Now, to me, that's more important than any numbers I can give you. I mean, obviously the numbers help and they're incredibly positive, but there are 11,000 stories like that to tell, 11,000 lives changed by this innovative approach to funding social prescribing, this joined up collaborative approach using local infrastructure at a place-based level. Now, by strategically developing collaboration between both the VCS FE sector and the health sector, the Thriving Communities Fund has generated this wealth of evidence for us to carry it forward into the next phase. So with this being very much a pilot project and I was seeing the successes from it, I guess the big question is what's next. Now, please be aware that this is very much a proposal and an early draft, so early that I've actually only been given permission to share it with you during the course of this webinar. So whilst the details may be quite vague, I can assure you that this is being worked on very much at the moment. Now, our aim is to develop a shared investment fund to support a sustainable social prescribing system focused on tackling health inequalities that enables our healthy, thriving communities. Now, we are proposing with the National Lottery Community Fund to work alongside NHS England and the new integrated care systems to run a shared investment pilot in 5 to 7 ICS locations to be launched in 23-24. We would be looking for initial investment from each ICS of approximately £500,000 to be matched and administered by the National Lottery Community Fund. So that is £1 million per ICS. Now, these funds will also be open to investment from the public and private sectors and individual philanthropists to support and build the provision of community-based activities, services, and information to benefit the local population's health and well-being needs. Now, if successful, this could provide an investment model for the future of social prescribing, generating greater sustained investment into the sector, and is something that we could potentially roll out nationally. This is our next big piece of work at NASP, and like I said, it's in the very early stages indeed, but we're receiving very positive feedback from all parties concerned. And that's kind of where we're at the moment. The message from NASP in terms of funding is that together we are stronger. We have shown that these collaborations between organizations across all sectors provide a much more risk-free investment for all kinds of funding channels. And that's something we want to promote through what we're calling our whole community approach. Our 7 regional leads will be going out into the field next year to try and bring these communities together, to upskill them, to build these networks, and to continue the work that Thriving Communities has done. And that's what we see as at least NASP's contribution to the future of funding for social prescribing. Thanks, Tim.
Thanks, Josh. That's really, really helpful. And I've just, Veronica's just asked if we could discuss funding a bit longer, and then we'll show the Portuguese video at 4:50. So we've got a bit of time just to explore the issues that have come out. And if I can see Mags as well, obviously we can't ask Chris because he was a video, because he can't unfortunately be with us. But I wonder if we could reflect on the fact that this is not exactly the most straightforward time to be seeking funding in England. Massive cost of living crisis. As I mentioned earlier, some of the funding that we can get our fingers on is going to things like making sure people know they can get advice as to how to turn their heating on. So how do you convince people with budgets that painting and theatre and pottery and all these things that we know are wonderful for people in decline, in preventing decline, cognitive decline, how do we really get them to put their hands in their pockets and fund these things?
I mean, I'll say to him, when is it ever a good time to talk about funding? It's always going to be a budget crunch. But I think, I mean, evidence is the key thing here. And something that our Thriving Communities regional leads will be doing next year is rolling out a very easy to use evidence collection system that will allow, because we're aware that, you know, a lot of the people that provide social prescribing are very small, incredibly dedicated and brilliant organizations, but evidence may be not their strong suit. And we need to be able to gather as much as we can, and working with our evidence collaborative at NASP, that's something that we can morph into a series of packages that can be directly targeted at certain types of funding streams, because we know what certain government departments or certain parts of the NHS or certain individual philanthropists want to hear, and then we have the ability to sort of act as a fulcrum around which all of that can be collated and presented in the right way. So it's all about working to show both the financial and the, I'm going to say, personal impact of the work that we're doing, because we know it works, that it's finding the right language and it's finding the right statistics, and we're getting there. I mean, like I said, we have the Thriving Communities Fund evaluation. There's a lot of really strong evidence in there, including 37 separate case studies. I mean, I only touched on some of the outcomes, but I could speak for about 1.5 hours on what we have. And it's just about getting those in front of the right people in the right way.
I think a really important point about the right people in the right way, because I think sometimes people can come at this from a very clinical point of view, not understand some of the importance of the wider determinants and that longitudinal change or risk of change. But absolutely, if you can help the systems to present, or particularly the voluntary sector, I think the arts sector, to present the evidence in the way that will press the right buttons, that'd be really helpful. Mags, in terms of your work, the same stories, but I guess to some extent you're coming at it from the art more than the health and well-being. But do you collect stories in the same way? Do you have the same evidence base to share?
I think we have a shared mission with the National Academy and other people. We fund directly some research projects. We funded some of Daisy's work, for example. And I think I think it's an area for us to develop. I mean, this is a bit of a personal thing for me, because I'm a part-time amateur academic in my spare time, and a lot of my the research I'm doing comes out of the social sciences, and so it doesn't rely on it looks to find causation in different ways. And one of the things I'd love us to be able to do as a collective is to recognise that randomised control tests are not the only way to show causation and effect. And so there's so much that we can go at as shared advocates for this over the next few years. So yes, it is important to us. I think we'll only achieve that strong argument by coming together. I know one of the things we're keen to do is to support the National Centre for Creative Health's new work. Our chief executive has joined the commissioners of that work to build on the very important APBG findings to bring some of that together and bring it to the attention of policymakers. So I think those sorts of initiatives are really, really important. I mean, in the short, there's a sort of feeling of, I suppose I sort of feel I'm a bit of a natural optimist, hopefully not a foolish optimist. I'd like to say, let's try and not get overwhelmed by the narrative of the economic downturn. It's going to be hard. There might not be much growth over the next couple of years, but if we're wise, what we'll do is build a development platform for growth, and maybe it will mean investing a bit less in some of the product we'd like to do, maybe a bit more in capacity building and networks and relationships, so that when the good times come back, we'll be really ready for takeoff. But also that economic pressures create opportunities. So, this feels like I referred to libraries earlier. I don't think anybody is content with the idea that libraries are having to be warm spaces for people this winter, but they are. And if that gets people in and gets the conversation going and builds community, then there will be some positive outcomes from that we should encourage.
It's funny you should say that, Max, because I was just about to mention warm spaces, because in a sense there's a captive audience there, some of whom will be from very deprived backgrounds, facing a lot of challenges, and possibly amenable to some, well, definitely the idea of people just sitting around in libraries all day doing nothing is not particularly attractive to anyone. So I think it's a really good opportunity to to link to stuff that's already around and that people can engage in. I think one of the other things that occurs to me in all this is that we've heard that volunteering extends your life, and it makes you happy. And I think there's a lot of people who come into social prescribing as people who are using services, who become volunteers, come out the other end as volunteers, and presumably there's nothing to stop them doing creative stuff as part of that, and being part of a self kind of growing network of people who share crafts and art skills and so on. And that's something we should be looking at too.
I mean, that idea has been germane to a programme that we've been running for a decade now, called Creative People and Places, which in many ways was one of the forebears of some of our approaches that have been formalized through the strategy of let's create, and the way, if you look at the evaluation of the Creative People and Places programme, I'm thinking of places like the BATE programme in North East England. I mean, that they show the real enormous potential for people to become engaged and then to become active volunteers, and to change their relationship with their place.
I can say that of the 11,000 people that were impacted by the Thriving Communities Fund, 414 of them were retained as volunteers by the organisations which they were initially.
That's the sort of evidence that I think there isn't an ICS in the country that wouldn't be pleased to hear. Because of the public health evidence that it's good for you to volunteer, but also obviously all the stuff about being a resource that's cost effective and building communities that can do these things for themselves. I'm reminded of during COVID first lockdown, we had a group, and I think actually we used some Captain Tom money to fund it, that made a blanket together. And they did it online. So they also, sorry, I know nothing about blankets, by the way, but they crocheted, sewed, knitted, whatever it is you do, and then somebody put it all together at the end, and then they could all look at this. And obviously the creative bit was really important, but actually really it was a medium through which they supported each other through really difficult times. And there was some feedback that said at one point, Fred would be down, and we'd be up, and then other times Fred would be up and we'd be down, and we'd help each other through. And I think that was a really powerful kind of example. It doesn't have to be, you don't have to be Gauguin, do you, to be doing something that is good for you and good for others.
You don't, Tim. What I would argue though is that the quality of the process matters. I mean, there can be, the public aren't stupid. They know when something's inspiring and high quality, and I think that makes a difference when people are really engaged. Quite often that looks like, it doesn't necessarily enormously expensive, but it might quite often involve a relationship with a very much an artist from that community, working with that community to release their creativity. It's a very special way of working, I think. So, but absolutely, I think we certainly as the Arts Council don't want to place any particular value on any type of art form. We want to place value on the quality of the work that happens.
And there's a point made in the chat about the length of time that funding was available for Thriving Communities. So obviously, Josh, you're saying you've been able to show really powerful outcomes from that. But how much of that funding was then continued through other means? Or, how much did that inspire ICSs or whoever else to fund continuation?
I have a background in funding, and I'm aware of the challenges of project funding when priorities change after 1 year and you're suddenly left with an absolutely huge hole to fill. It's in the region of 90% of the Thriving Communities funded projects are still running, having sourced outside funding, but I'm hugely aware that 1 year is not enough. And like I said, this is very much a draft proposal we're working on at the moment. Nothing is confirmed, nothing may happen, but it would be a 3-year funding cycle we'd be looking at, and that wouldn't necessarily be specific project funding either. I'd be looking at being able to fund core costs, for example, which is so often forgotten by the major funders, but keeping the lights on is just as important as delivering activities. So, and of course, as Anne mentioned in her comment, with a 3-year funding cycle, you're so much better able to track the impact that the work is having and grow the work. So that's kind of where we'd be looking at going forward.
Yes, I think there's something really important there about the cost of evaluating stuff as well, isn't it? So one of the things that we're talking about with this sector in our patch is if the statutory sector is expecting all this data and evidence, then it has to be able to resource that as part of the overall resourcing. And obviously we might be able to make some savings by getting people to collaborate on that rather than everybody doing it separately. And I think somebody in the chat mentioned the possibility, or is there the possibility of some sort of standardized health outcomes from art measures that we could all use, so we're looking at stuff more consistently. But I think it is a fair point that data costs money, and it's probably even telling stories probably costs some money. It's much easier to tell a story about the patient that you had, that if you're a doctor, that well, that really changed their lives, blah blah blah. It's much harder to get all that hard data together.
Absolutely. It's not just data, Tim. Data costs money, volunteers cost money, tea and coffee cost money, and it's all that sort of thing that often really aren't hardwired in to funding. It's always going to be supplementary to the project, and in my opinion, that's absolutely not the way it should be. It's much more holistic than that.
And is there any sense in which we've got experience of the private sector getting involved in either the follow-up to thriving communities, or with yourself, Mags, with the Arts Council, in actually seeing a role for sponsorship of this particular type of artistic activity?
I think it's an active conversation amongst some of the well-established arts donors. I can't think of an immediate example of a specific project that's led to a specific outcome, although I'm sure that there are examples of different funders and donors that have put money into projects. So I think I remember James Sanderson, previous conversations I'd had with him about this, and talking about mixed economy here, and that feels important, and that this may not always be big donors, great as big donors are, and what knows, but it might be sort of like the local economy of a local business or something playing their part in this. So it's a really interesting development.
Can I add to this? I worry about it though, because the whole reason for really loving your arts health approach is that arts trust funding, etc., is so short term as to not be useful for social prescribing, and I think and it takes such a long time to fundraise in that way. Whereas if you have a collaborative funding, altogether collaborative funding on the lines of your original Arts Council, Sports Council, Thriving Communities, it's a much better way of raising awareness, working together, collaborating with people who lived experience, a whole lot. Whereas if we go back to the old way of getting private funding, it might be short term. Given us such a lot of fodder here. I can't wait to transcribe it, because you really have, your help has been invaluable, and all the things that and if there's anything else, of course, you want to state, please do. But before speakers go and things, could you, if you have any text and you have any PowerPoints you haven't already sent, could you send the text to me so that it helps me when transcribing, and send those research links. A lot of you have mentioned wonderful resources, and we'd love to share those. Tim, that was the most amazing, debate. I'm so glad we were able to have one, and especially when you know so very much. To thank Tim for chairing the funding session, which we all need to know about, because so many people plan the most wonderful programs, and the challenge is very often to raise awareness and of those programs. So the collaborative way is wonderful, but to have NHS charities together, to have Tim, who knows so much about the NHS, actually there talking about ICSs, and then to have Mags from the Arts Council England, who we are really interested to hear the way forward you're thinking, and it's terribly, terribly exciting. Thank you to all our speakers. I should also like to thank my brother Nigel and Arts for Dementia Associate for his wizardry in spotlighting speakers and actually helping with all those recordings and behind the scenes. And I'd like to help behind the scenes our volunteer, Amisha Palmer, who gives her time to edit the recordings, and she is terribly busy volunteering at hospital. So we are very, very grateful. Bogdan, you are an inspiration, and it has been a real privilege to host this conference with you in partnership with the Global Social Prescribing Alliance. Gosh, how you motivate us, and I look forward. I would like to give you the last word. So thank you very much. And I'd like to hand over to our magnificent co-host, Dr. Bogdan Tivajurka.
Veronica, thank you ever so much. I don't think there's much more to add than to thank you wholeheartedly for bringing us all together as you beautifully do all the time. You've convened here a series of fantastic speakers, and I'm more surprised by the incredible audience who's been contributing throughout on the chat, staying very active throughout. It's been a long 3 hours, but I think I speak on behalf of everyone to say that it's been full of energy and full of knowledge that I'm sure we'll be able to revisit through the recording. So huge thanks to all the speakers, huge thanks to all the partners. Please reach out, please connect, each one lift one up. The social prescribing world started as a movement, like many of you have described it, a grassroots approach of people who are supporting each other and pushing this agenda further for better health for all across the world. Once again, big thanks, Veronica, for such a beautiful webinar. Many thanks to our speakers and chairs, and we look forward to welcoming you to yet another one in the new year. Thank you all.